respected chairpersons, uh, my teacher, Professor Emeritus, Professor Sufia Rahman, and all other dignitaries. My paper is LM Troubleshooting, How Can I Bail Out? This is the patient details. I do not want to see as because time is limited. What is the shadow in the left main? দেখা যাচ্ছে না না কমরোল আসছে দূরের থেকে অবশ্য তো ভালো দেখা যাবে না দেখা যায় না এটা আসছে না তো এটা আসছে না কামরুল গলাটা কাটে বলো if we see from close then we see that there is a ghost shadow in the left main and as because it is far away from the from our chairpersons I do not know whether they are seeing
রান করছি স্যার এখন স্যার এখন করছি স্যার
আগেরটা বলতে still picture this is the still picture and this is the initial scenario of the patient left main involving the ostium of the left circumflex and minimal lesion in the ostium of the LAD and we have done the right side is normal distal LM 30 to 40% approximately ostial left circumflex 90 to 99% with RCA normal caliber and LAD may be some plaque extending to the LAD and so here the syntax score and syntax score is 23 and we have done the IVAS pullback from the left LAD to left main as well as left circumflex to LM where in both the vessels IVAS is used and let us see what IVAS shows us. It showed that ostium of the left anterior descending artery is not significantly narrowed but there is significant narrow of the left main. This is on the left panel. On the left panel, this is the left main, and in the middle panel, LAD ostium. LAD ostium is 5.54, and next LCX ostium and LCX ostium we have also pulled back done from the left circumflex, and left circumflex is significantly narrowed. And that is why we have decided to do the intervention from left main to LCX. And accordingly, we have pre-dilated the left circumflex as well as we have deployed on a stent from left main to left circumflex. And this is the result after left main to LCX stent deployment seems to be good. Though there is some haziness in the left anterior descending ostium of the left anterior descending. We post-dilate the left circumflex as well as we have done the port and we have recrossed the LAD and we have done a KBI with LAD. And this is on the right panel, this is the result after KBI. This also looks good. And we have done IVAS from left anterior descending to left main, which shows significant plaque shift causing narrowing of the left anterior descending ostium of the left anterior descending coronary artery. So we have decided to give another stent to the LAD in the fashion of tap. And accordingly we have done the tap. After tap we have done the KBI, and after KBI we have done the port, and before just after doing the port we have seen that there is a ghost shadow in the left main. Then what is the proximal part of the left main? Luckily my two wire was in situ, meaning that one was in left circumflex and one is in the left anterior descending artery, and I recrossed through this shadow sequentially from a small balloon to larger, and I have post-dilated this ghost shadow. In the middle panel, you are seeing the stent, distorted stent, how ghost-like shadow in the middle panel. And we have done the post-dilatation on the right panel in this ghost. And finally, after doing report on the right panel, you see the stent is inflated, but there is Vijay shadow of the stent. But what shall I do? Shall I put another stent here? Where to where? In which vessel I shall go? And that is why I have seen the last scenario. This is the scenario. Angiographic view is good, even though the stent is distorted, but patient is hemodynamically all right. And as because patient is hemodynamically all right, there is TIMI3 flow, and there is no impairment of flow in the LAD and LCX. At the moment, patient is all right. So I sent him to coronary care unit, and patient is all right. And this is my first case. And another patient, a 56 years woman, who had the history of non-STMI, post-MI angina, LVEF 44%, and this was the coronary angiographic findings. Not moving. RCA was normal, and on the left side, slide was not moving, but there was a significant lesion in the left circumflex as well as mid LAD. This is the second case, and you see on the right panel significant lesion in the left circumflex, and LAD is a doubtful lesion. And the performer wanted to, right side is normal, and performer wanted to do the left circumflex, and he was trying to left circumflex, and you see in the first cine on the left side, both left circumflex and LAD is closed. Just distal to the wire, the left circumflex, and from mid LAD, both are closed. Emergency call back, then they called me. Patient developed chest pain, hemodynamically became unstable, patient is mother of a doctor. What are the possibilities? Dissection, thrombus, spasm, what to do next? Whatever it may be spasm or dissection, I shall have to open. And so I tried, I went there and withdrawing the wire from the left proximal part of the left circumflex, tried to cross the wire into the LAD first and making a loop, and you see this is the picture. In the second view, it has shown that there is dissection from the left main, which comes up to the distal part of the LAD and LCX. Both LCX is closed and LAD is closed due to this dissection. However, keeping that wire into the dissected part, I have crossed another wire into the LAD, and CPR was giving, and subsequently I have hurriedly I have given 2 stents sequentially from distal to proximal. And after giving this stent, though I am seeing that proximal LAD there is still dissection, but I have to treat the left circumflex as because I shall have to cross over. And that is why, keeping in this condition, I have crossed the LCX lesion and pre-dilated the LCX, and I have given 1 stent into the LCX. And after giving this stent, then I have given LM to LAD another stent and post-dilated, and this is the this is LAD and this is LCX. Both the vessels are patent, and my job is over. Treatment decision should depend on each patient and each lesion. In bifurcation lesion, provisional single stent strategy is still the default approach in majority of cases. Here is not bifurcation lesion, but it is the iatrogenic bifurcation lesion. And the left circumflex ostium is always a mystery, even you have done all the things right. Ostial branch lesion. Ostial branch lesion does not come alone and usually involve main branch. and complication of PCI management requires preparation, early recognition, and knowledge of effective techniques with good team effort. And this is my team, and we have finally saved the patient.